Good afternoon, everyone. My name is Madeline Frankel, and I am Tannenbaum's Healthcare Program Associate. And on behalf of Tannenbaum, I'd like to thank you all for joining today's Conscientious Care Conversation about religion and mental health. Maria, can you please hop to the next slide? We are the Tannenbaum Center for Interreligious Understanding, and our mission is to promote justice and build respect for religious difference. In healthcare settings, this means respecting patients' practices and beliefs as it relates to their care. Therefore, in our healthcare program, we strive to ensure that patients of all religious faiths and none receive religio-culturally competent care. Next slide, please. So I am thrilled to introduce today's expert panelists. Our Healthcare Program Assistant Director, Maria McQuaid, will be moderating today's discussion. First, I'd like to introduce Dr. Caroline Kaufman. Dr. Kaufman is a clinical psychologist and a postdoctoral research fellow in the Spirituality and Mental Health program at McLean Hospital with a dual appointment at Harvard Medical School. She's the program chair of Division 36, which is the Society for the Psychology of Spirituality and Religion. Her research interests are at the intersection of spirituality, adversity, and mental health. Next, I'd like to introduce Tammy DeYoe. Tammy is the Behavioral and Community Services Director for the Seneca Nation Health Department. Tammy is a licensed clinical social worker with psychotherapy practice privilege, and Tammy's practice focus is on human services in social work. She brings extensive experience in providing individual, family, couples, and group counseling in both mental health and substance abuse. And finally, I'd like to introduce Dr. John Petit. For over 40 years, Dr. Petit has been a psychiatrist at Brigham and Women's Hospital and the Dana-Farber Cancer Institute, where he is an associate professor of psychiatry at Harvard Medical School. Dr. Petit is a distinguished life fellow of the American Psychiatric Association and the former president of the APA's Caucus on Religion, Spirituality, and Psychiatry. Dr. Petit has co-edited 12 books, along with numerous papers on the clinical interface between spirituality, religion, and psychiatry. So without further ado, I will hand the conversation back over to Maria.
Thank you, Madeline. Let me just stop sharing so we can see all of the panelists today. Thank you for that lovely introduction. And again, thank you for all the panelists for making the time to be here to have this conversation with us today. So just to get started, Dr. Kaufman, if that's okay, I'll start with you. Can you tell us a little bit about your role and how religion and spirituality impacts the work that you do?
Thank you so much. So I'm a postdoctoral research fellow in the Spirituality and Mental Health program. And as part of work, we really have three arms. The first being clinical work in McLean Hospital and other affiliate hospitals of Harvard Medical School, where we focus on spiritually integrated care and across units, across patient types. Our second arm is research, working to enhance evidence-based spiritually integrated care, and we have a couple of studies examining that right now. And then our third arm is dissemination. So we try to disseminate our research via academic journals and publications, as well as mainstream publications, and even moments and interactions like this where I get to speak with other people in the field. Spirituality is in the name of our program and what we do, but I really try and consider spirituality and religion to be aspects of diverse identities and experiences. And because of that, I put a heavy focus on that aspect of identity and experience when salient in both my research and clinical work.
Thank you so much for sharing. Tammy DeYoe, I will now pass it to you if you're ready to share. So just, can you tell us a little bit about your role and how religion and spirituality fit into that?
Currently, I'm a director of 5 different programs. I run a behavioral health providers, Seneca Strong, which is a peer-run recovery program, child and family prevention, and care collaboration. So working with mental health and addictions, it is expected to have religion and spirituality as a piece of their treatment. because I'm working for a Native American population, we focus a lot on the spirituality aspect and culture and becoming, understanding their history and historical, as well as, adding in religion of anybody that maybe doesn't follow Longhouse or spiritual components. So I feel it's really important part of them getting well, whether it's mental addiction, even if it's family work, child welfare, any of those pieces. So religion and spirituality really are an imperative part to all the programs that I do work with.
Thank you so much for sharing. And now Dr. Petit, same question for you.
Yes, I'm a psychiatrist in an academic medical center working on the consultation service and also seeing outpatients. I have a small private practice. And I've been impressed over the years with the importance that religious and spiritual issues have in patients' experience of their illness and recovery. And so I've been part of some research into the importance of spiritual and religious issues at end of life, but mostly have pursued teaching and writing. I co-teach a course to our psychiatry residents, spirituality and psychiatry, and also co-teach a course at the medical school, spirituality and healing in medicine, which draws students from the divinity school and the School of Public Health, where we look at how all of these issues come up in different faith traditions for clinicians and patients.
Okay, thank you so much. That definitely gives us a lot of background information. And I just want to thank you all again for being here to have this conversation with me. Now, Tammy, I have a question for you, and then I can also extend it to the rest of the group as well. But how does the community that you work with, how do they approach mental health? How do they approach mental illness? And what does that look like exactly?
That's a large question.
It's a broad question, I know.
I think I believe there's still stigma attached to whether it's mental health or addiction. I feel that it's important to educate the community on, mental health. It's like 1 out of 2 people have like a mental health diagnosis. Unfortunately, most people with addiction have either trauma history, they have depression, anxiety. So I think, the community is opening more and more to, having mental health and addiction treatment services available. But I still feel some people, have a lot of shame, maybe guilt, that causes them not to maybe want to seek treatment. And I think, the communities, the tribal communities are smaller here, so everybody kind of knows everybody. So sometimes people do look, not often, like outside of the community for assistance. So I really tried to do a lot of outreach, education, breaking that stigma for people to say, we're here to help you. There's no judgment. So I think that's like a really important aspect is really breaking that stigma that still, stands today for the mental health and addiction communities.
Absolutely. And Dr. Petit and Dr. Kaufman, would either of you like to tackle that question? I'm happy to ask it again if you'd like me to. It's how does your community, or how does the community you work with, approach mental illness or mental health care?
Dr. Petit, do you mind if I go first?
Go ahead.
Oh, thank you so much. So my clinical work has taken place across a variety of contexts with a variety of patient populations. I'm technically an adolescent psychologist with the bulk of my training in intensive treatment settings. And I can tell you that sexuality shows up a lot of times for our kiddos or young people around transcendence or this feeling of connection. And we may not hear these words, God, prayer, church, temple, mosque, that we might hear among people of a different age or generation. I've also done quite a bit of work with trans and gender nonconforming adolescents and their families, where spirituality and religion can be a great source of stress and even distress. And working with those young people and families while making sure it's culturally accurate for them and relevant for them, seeing if we can be flexible and include spirituality and religion not as a source of stress, but either a neutral factor or even potentially a source of resilience or strength. I can tell you that in my own personal life as a Jew, the guiding value of my life is tikkun olam, which like roughly translates to repair or heal the world. And in that phrase, I hear two assumptions. First, that the world is broken, which who works in mental health, I think, can tell you is true. And second, that there is an imperative to address that brokenness. So that really drives my clinical work and research in this area.
Thank you. And now, Dr. Petit, would you like to answer the question?
Sure. I could say within the medical community where I work, there is more recognition now, I think, of the relevance of religious and spiritual issues for patients, and that patients want to be included, asked about this area, but there's still not a lot of spiritual care being given other than by chaplains within the medical context. And I would say within my Christian communities, there's a wide range of openness to thinking about mental health issues. Generally, mainline and Catholic churches tend to be more open than more conservative Christian communities, which may be suspicious of secular mental health. And so there's work to be done in terms of religiously reinforced stigma against mental health within some of those communities.
Absolutely. I think that religion and spirituality within medical and scientific communities has been kind of a taboo subject until recently, and it's still a subject that people have a difficult time navigating or even kind of building their comfortability with talking about it. So hopefully we can kind of build people's confidence just with our conversation today when it comes to talking about religion and spirituality in terms of mental health. But Dr. Kaufman, I think you raise a really good point that religion can have both a positive impact or a negative impact. But either way, if the provider isn't asking about it or talking about it, then you are missing a large piece of the puzzle. So I guess that leads me to my next question, which is, how have you seen faith or spirituality or belief systems impact mental health care decisions? And whoever wants to answer that question, feel free.
I'll start. I would
Okay.
say that, yes, I feel that mental health can be affected by your faith or beliefs. Dr. Kaufman, I've worked with the LGBTQ population, and there are times when people won't seek treatment for that issue or concern because of their religion or their values and morals of the family, or maybe the parents won't allow that child or teen to look into their gender, look into their identity, to work through any issues that they're having, struggling. So I feel like, that spiritual and religious beliefs can impede mental health treatment. But I think it also can actually help on the other spectrum of it, of somebody looking for some support, belief. We do a lot of holistic treatment here at the Seneca Nation for Seneca Strong. So that has actually drawn people in for more like, energy healing, Reiki, sound baths, things like that, of the spiritual of component versus maybe the religious component. But I feel like it can be like both ends that can either help or hinder, depending on probably the issues or concerns that are being presented.
Absolutely.
Yeah, I would agree with that. It can be a positive or a negative thing. Sometimes people are depressed, but are being seen by their community as lacking in faith and needing to pray more rather than getting mental health treatment. On the other hand, religious beliefs, spiritual practices, supportive communities can all be very important in someone's sustaining someone and helping them recover.
Yeah, and I think we definitely, I was just going to say, I think we definitely see that in a lot of support groups like Alcoholics Anonymous or Narcotics Anonymous. There is this kind of spiritual component that gives people a connection to a community and kind of this social support system that maybe they didn't have before. But sorry, Dr. Kaufman, I think I cut you off.
Oh, no problem. I just want to mention there is some research to say that when we as clinicians describe mental health treatment or mental health issues using the biomedical model, There's research to suggest that this may sound more stigmatizing to highly religious individuals. Most of this research is done among Orthodox Jews, but it has given me pause to think about how I describe and talk about mental health and mental health treatment in a way that is the least stigmatizing, most flexible, most open, so that if it fits or works for people, it may feel comfortable seeking treatment or help. My other thought is I once had a supervisor describe therapy as a buffet, where there's all these different choices of things you can talk about and include. However, for a variety of reasons, not everybody knows what's offered at the buffet. And we need to tell our clients. I can tell you I've had more than one client say, but I don't think I'm allowed to talk about religion here, right? They have no idea that sort of everything's on the buffet, and making that clear to our clients in case it might be salient or relevant. And of course, there are cases when it is not, but letting people know it is still on the buffet.
So, oh, sorry, go ahead.
I was just going to say that's one of the reasons we try to encourage our trainees to ask a new patient if they've been a religious or spiritual person and listen for what they have to say, because it gives them permission to look for that on the buffet.
So what can communities or providers, what frameworks can they use or engage in that would better help them kind of approach this issue around religion and spirituality, and making patients know that this is a conversation that they can have and that it is appropriate to bring up in this context?
I like to say, like Dr. Petit said, just being really open and upfront and honest and saying, can you tell me what your spiritual or religious belief is? There is no judgment here. We want this to be part of your treatment if it's something that you choose, or if they have no belief, can you explain that to me? You know, like really sitting with them to say, tell me what your belief is. And well, I was raised Catholic, but I'm more spiritual. And I think it's from where I have been employed for the last 15 years is more of a spiritual belief system, where my sister maybe is more religious based, attends church every Sunday. So I think a lot of it is sitting with the person, making it very upfront, honest. Can you tell me about it? Listening to them and asking them, would you like this to be part of your treatment? Would you like to have it more information? Do you need assistance with it? And if they say no, okay, you kind of table it. But if they say yes, and you're not aware of it, then you figure out like who you can connect that person with, how you can get the resource. Is there somebody in their community? So I think really just having that basic general discussion.
Yeah, so that kind of brings me to my next question, which is for all of you. What steps have you taken in your own practice to be mindful of patients' religion and spirituality, and to make sure that it doesn't become an overlooked part of their care? And what steps can other providers take? I mean, I know being honest and upfront, but I think there is this, providers tend to just lean on the practice that they already have. So how can they incorporate new pieces to their practice that take this into account?
And certainly, I think it depends on the context. So I've worked in environments where the psychologist is the leader of the treatment team, where the psychiatrist is the leader of the treatment team, or the social worker is the leader of the treatment team. And thinking also about your power and role in that place. In times where I've had the opportunity to design my own intake forms or conduct my own intakes, I will use those demographic questions that Dr. Petit and Tammy referenced in first identifying, do you have a religious or spiritual tradition? Might you want to see that incorporated in our work together, or not incorporated? If not incorporated with me, if your hospital or treatment center allows for chaplain referrals, is that something that you might be interested in? Would you like me to put that in your chart for you? In cases where I haven't had as much power for whatever reason, depending on the hierarchy of the treatment team, during rounds when we talk about our patients, I will ask, oh, and did the patient mention a spiritual or religious tradition? In a calm, humble, curious way, if only to prompt clinicians and members of the team to wonder about that, even if they failed to ask. Let's wonder about that. And I also ask fairly pointed questions sometimes. Do you think this presenting problem is tied into or connected with the difficult or spiritual distress that your patient reported? Just to ask, to prompt, if at all possible.
Yeah, that's great. One of the things that we've done is to, when we have rounds about the patients that we've seen who have cancer in the hospital as a psychiatry service, which we do every other week, to invite the chaplain in to talk with us about the patients that we share. We often see some of the same patients, but don't always have a chance to talk about them. And so hearing about the patient from the point of view of the chaplain and what they're doing with them can be an opportunity for us to learn from them how they talk about some of these issues, areas of the patient's life that we might not have appreciated, and also gives the chaplain a sense of how we're thinking about the case.
I think also too, like for us, a lot of cultural and spiritual, we're looking for resources in the community. Like, do they have a faith keeper? Do they have, are they connected with the men and women ceremonial? Do they need a ceremony? If it's religion wise, do you have a local church? Do you have a pastor? Do you have a priest? Is there a way that we can help get you connected? So I think the linking piece is really important. And again, maybe somebody's like, I'm not really sure. Okay, would you like to explore that? Would you like to talk about it? And just really gathering more data of maybe what they were brought up with, what their thoughts are, because we all don't know every religion and what aspects. So we're not, saying we're experts in that. So we want to make sure that we have education as well as connecting for people to find themselves or find a piece of themselves through spirituality and religion in regards to treatment or let's say cancer wise, they're unfortunately nothing you could do. You're moving forward towards the end of life. You want to make sure that they have some type of peace and a connection to something.
Mm-hmm. Yeah, so it seems like what you're saying is maybe actively incorporating these complementary and alternative practices that already exist into patient care can be really helpful for patients. I know that's something we talk about at Tannenbaum. I think that can be hard for most providers, like you said, that have no background in religion or religious differences or religious beliefs and practices. So yeah, how do you, I think learning a little bit about the communities that you work with, if you're not a person that's involved in that community, could be a good place to start. But is there anything else that you suggest to kind of help providers better meet the needs of their patients that are already involved in these spiritual practices and belief systems?
There is some research, and it's a little bit dated at this point, that religious leaders may be less likely to encourage their to seek mental health or psychiatric treatment for a variety of reasons, historical and current. I think in places and times when physicians, mental health professionals, treatment centers have the time and flexibility, it is worthwhile to reach out to those communities to create partnerships, most ideally partnerships, but most basically just a connection. Hi, I'm Dr. Kaufman. I work at this hospital. Tell me about the work that you do. Tell me about your community, just to identify yourself as someone in the area who is open, interested in hearing about this perspective. So that's maybe we can increase religious leaders' likelihood of saying, well, you might consider mental health treatment, or I've heard at this institution there are people who have connections with or are respectful of our community. And I do realize I'm asking quite a bit of providers who are already working extremely hard. And I also think, again, about how many patients and people don't get to see us for a variety of reasons. And perhaps this is one reason that we can address or think about.
Yeah, I think it's helpful for us as mental health professionals to know people in the religious community that we can learn from, refer to, and similarly for pastors, for example, in the Christian tradition, to have some mental health person that they know that they can refer to, that they trust, because they get a lot of people who have real needs, and we can sometimes consult with them and sometimes see their patients if we have the time to.
And Dr. Petit, I think you used a really interesting word, which is trust. And Tammy, I would like to direct this question to you first, but then open it up to everyone more broadly. But I think that particularly within Indigenous communities, building trust in the medical system can be difficult. And I think Dr. Kaufman, your point of just being a presence that's in the community, making those connections is a really good place to start. But for certain communities, there is just this history of exploitation, of mistreatment. So how can providers, specifically mental health providers, start to better engage with these communities who have been marginalized, who have been disenfranchised by the medical community at large?
I think the first thing as a provider working with Native American population is to be one, humble, realize that, you are, unless you are part of the community, you're coming in as an outsider. So not having any preconceived notions, not having any like, I'm going to save the world type of aspects. I think it's coming in and saying, I'm here to help, but also too, like, learning from the population that you're working with, understanding that there's been historical trauma, understanding that maybe their last counselor didn't work well with them. I think the other piece too, kind of tying into the last question, is being very mindful of your own values, morals, religious beliefs, and really taking a step back and making sure that you're not pushing any of your prejudice, discrimination, values, moral biases into that counseling, because we can always come into a session or a population or a culture with preconceived notions, and that's going to not help us build the trust. So really it's being humble, being open, learning from the clients that you're working with, learning from the community. If there's a community event and you can attend it, see what it's about, ask questions. If you're not sure, seek out somebody that's maybe very knowledgeable regarding the culture or spiritual or religious components. But I think also too is have avenues as well. Maybe you're not the best person to meet with that individual. Maybe they want a Native American counselor, maybe they don't. So we see kind of both sides of it. So really just being kind of like humble and mindful of person's a human, and you want to make sure that you understand the holistic part of them. And really just understanding that you're not going to be maybe welcome with open arms. It's going to take you a minute to have people trust you and realize that you're here to help.
Right. Would anyone else like to touch on that or expand on that at all in terms of maybe the work that you do, or how you think other providers should engage with these communities who have experienced significant trauma?
I agree with that. I just think if you know people in the community who they are more likely to trust, it's helpful to be able to make those connections too.
Yeah, absolutely. So I would also kind of like to address the elephant, I guess, on the world stage, which is COVID-19. So I think that has had a pretty significant impact on mental health of communities that are already struggling, but also I would say everyone. COVID-19 has touched every person's life in some way. And I would say I think it's fair to say it usually has been a negative impact. And a lot of people are experiencing mental health issues that maybe didn't experience mental health issues before. And we are also struggling to connect with each other. I mean, it's hard to find spaces to physically be together. So I guess my next question would be, how do all of us, not just providers, how can we be there for ourselves, but also for people that are struggling during this difficult time? I know that's a broad, difficult question, so I'll give everyone a minute, but whoever wants to start, feel free.
Just from a perspective of a trauma provider, it's very difficult to treat a trauma when it's still going on. And I think for many reasons, and for many of us, COVID is still going on, even though for people or some news outlets, it may not seem like it is. But certainly when I think of spirituality and meaning making as a part of spirituality, is first acknowledging the hurt. And as part of that, acknowledging that it hurts where it matters. And for many of our patients and ourselves, where it is hurting right now might be connected to our values, whether spiritual or not. So for me, with my patients and in my communities, is first acknowledging that hurt. And unfortunately, Maria, I'm not sure I have a better answer for you beyond that, because I still see this stressor as very much ongoing.
Absolutely. I mean, we are still in the midst of a pandemic, so I totally understand that we're all still trying to navigate and figure out how we can support ourselves and support others in the midst of this collective trauma.
And I think there's two sides to the pandemic. So we've seen like a huge influx of mental health. Addiction, unfortunately, has always been high. We have the opioid epidemic going on. That has continued. But we have seen through the pandemic, like our numbers have either doubled and tripled. So I think there's like the piece of, you could look at it two ways. One is we've gone to like a lot of a lot of virtual, a lot of video. So we live kind of in a rural area. The one reservation is very rural. So like, I think there's two ways to look at it. One is we're actually able to maybe meet more people's needs because there's more access, there's more less barriers with transportation, daycare, etc. But then again, we have a pandemic that there's been a significant amount of loss. So I think like Dr. Kaufman said, almost like more trauma on top of more trauma. So I think there's like almost like two sides of this pandemic is we've learned to navigate through this very difficult time as providers and agencies to meet more needs. So I don't know if it's an increase of mental health due to the COVID-19 or an increase in mental health because there's more COVID-19 and people are more accessible. But I also feel too is we have learned how to, people are attending church online, they're attending AA meetings online, like they have more support groups. We've gotten really creative. But I think on the other side, again, like we said, there's trauma, but I feel like as healthcare providers or counselors or doctors, I feel like we're more stressed and more stretched. So it's like that self-care, which I think probably most healthcare providers aren't doing because the pandemic is ongoing, is probably more of the focus that probably we should take a step back and say, what can we do to help the healthcare industry a little more? Because I don't see it going away anytime soon. I don't see the numbers going down. I see us probably reaching more and more and more. And like people are just getting to the end where they're like, I just can't take anymore. If that makes sense.
No, I think that absolutely makes sense. And I think that that is a really good point to bring into this conversation, which is that providers are also experiencing mental health issues. People involved in the healthcare field are also experiencing mental health issues. And I was reading something the other day about, instead of referring to it as burnout, referring to it as exploitation, because that is essentially what it is. And it's being overworked, working too many hours, not having the support that you need, not having the resources that you need. That is something being experienced by almost everyone in the healthcare field right now. And I know a lot of people are actually leaving the healthcare field because it's becoming too difficult for them. But Dr. Petit, did you have anything that you'd like to add to this part of the conversation?
I was just thinking about how it is hard for a lot of people not to be able to gather in person for worship services. That's getting better for some people, but also that Zoom has been a helpful avenue for working around that. And then also just the issue of vaccine resistance being connected to people's religious identity very often and causing strains within families. I've certainly seen that as another aspect of this.
Yeah, absolutely.
And Dr. Petit, I'm so sorry, Maria.
Oh no, go ahead.
Dr. Petit, I'm really glad you brought that up because there is more and more research coming out that potentially vaccine hesitancy could be more related to political affiliation, political views, and also intake of news media over and above religious identity. And I can tell you as a Jewish person, sometimes seeing the coverage of a supposed unwillingness to get vaccine or vaccinated among Jewish populations has sometimes felt unfair and or targeted, and also a misunderstanding of different communities. And I feel that during this time, we've had to be very careful with how we talk about vaccine hesitancy. And there has in some been, seems ironic to use the word demonization, but this portrayal of religious communities as deeply problematic, or religion is getting in the way of this care. And more research is coming out that it may be much less related to religious identity and even religiosity than we thought.
Yeah, I agree with that. It's just that for a lot of people who are vaccine hesitant, it seems as though they can feel as though it's tied into their religious identity, and it takes on that kind of intensity for them.
Yes, absolutely.
And I also think a lot of these groups, more isolated groups, are intentional targets of misinformation campaigns. So it's not really coming from any kind of fundamentalist understanding of religion, but rather kind of these external secular groups that are intentionally leading campaigns to mislead people. Which has a very strong impact on communities that don't have other news sources available or aren't as technologically connected as other communities. But I would love to open it up to questions now. I know we have a lot of participants on this call, so if anyone has a question for any of the speakers, please feel free to share it in the chat or in the question and answer bar, and I can ask that to all of the speakers. Or if there's a speaker that you particularly want to hear from, just note that in your question. So I'll give everyone a minute. Okay. So we do have a question. I think it's for all the speakers. What strategies have you found helpful in recognizing and dealing with the spiritual impact of racism and other isms, soul wounds, and social suffering? So whoever would like to tackle that question, feel free.
Can you read the question again for me?
I can, yes, no problem. What strategies have you found helpful in recognizing and dealing with the spiritual impact of racism and other isms, soul wounds, and social suffering?
Ooh, that's a big one. I think depending on the person, and it's depending on their belief system, I think spirituality can be part of the healing process. I feel that being connected to, whether it's, a God, a higher power, something greater than themselves, can help somebody move through maybe trauma, mental health issues. I think racism or any ism, I sat on a panel, that's how we met, on racism. And, you'd hope that we'd be somewhere different in the world today in regards to racism and prejudice and discrimination. We're better, but we're not where we ever want to be. And I think that spirituality, helping a person heal, is important, but I think there's so many pieces to racism that you would have to address, whether it's historical trauma, whether it's family dynamics, whether it's community-based. I think that that's a real loaded question where that could be a whole different panel discussion. But I feel that, being connected to something for healing is going to help somebody move through maybe what's happened in their own life. But I feel like, the racism that's still apparent there, that you probably need to have support, maybe through people who have experienced it, who understand it, education. Again, I think there's just so many pieces to that question that it could be a whole discussion. I'm not sure if I answered it or not.
I think there has always been utility for me with patients who identify as religious or spiritual, noting the difference between the world as it could be, it should be, and the world as it is. And there clearly is a gap between those things. And that may be especially true for people who are spiritual or religious, noticing that gap. And for me, part of treatment is noticing that gap and saying, can we still make meaning in the context of this gap? Can we still engage in values-based behavior? Can we still enjoy our community or contribute to our community? And my hope is that through treatment, we can end up saying yes to all those things, while still recognizing this gap that some days seems wider than others.
I'm just thinking that in terms of my own medical community, both the hospitals where I work have had some active DEI trainings and discussions and committees going on that I think have raised the consciousness of these issues. And what's been particularly helpful has been talking about them in small groups, which include some diversity. But there's also been an effort to have some larger gatherings after George Floyd, for example. There were hundreds of us in white coats out on the hospital's front lawn together, which had a spiritual sense to it. I think we're coming together around something larger than ourselves.
Okay, thank you for sharing. And we do have another question from Dasha Tanner. Do you see any spikes in mental health treatments needed during or around periods of the year heavy with religious holidays? And I think that is for all the speakers.
I don't think we don't see, it's mostly seasonal. I feel that, it's more around holidays like Christmas, family gathering like Thanksgiving. And then we usually February, March, of course, as we all know, is very high suicide, depression months and rates. At least, I feel like for us, there's nothing kind of connected to specific religious holidays. I think it's more family gathering components where maybe somebody's more lonely, can't get to their family. I know the pandemic caused a lot of depression around the holiday time, but I don't know if it was based on because it was Christmas or Thanksgiving or it was Easter. I think it mostly was on the inability to gather, the inability to travel, and then people coming back and being ill. Some people, I think the other piece too, when we talk about the COVID-19 pandemic, is people that maybe weren't vaccinated that ended up with COVID and they gave it to their elderly mother or they gave it to their family members and they died. And then you had a lot of shame and guilt, which, again, coming back around is it's almost like media or social had said it's your fault. And it really isn't. It's a pandemic. So I would say mostly it's around, I think, seasons. That's when we see more of the increase.
I would agree with that, although I think sometimes it's hard for some patients anticipating Christmas when there have been family and maybe spiritual issues connected with it. And then I've seen a bipolar patient or two who has a hard time with Easter, tending to get manic with the stimulation and the excitement. Maybe it has to do with springtime, but it seems to focus on Easter for some patients.
I would add in religious communities where fasting might be a practice, or lower intake of food or calories, or exclusion of certain kinds of foods for certain times of the years. I have seen to sometimes be an antecedent to the recurrence of eating disorder symptoms, and working with religious communities to wonder and think about that, if there can be more exclusions for fasting or reduced eating for individuals with a history of disordered eating.
Yeah, that also kind of makes me think, I think a lot of people that have experienced mental health illness and mental health issues in the past, and I'm including myself in this, rely heavily on routines in order to maintain stability in their life, to maintain stability in your emotional and mental state. And religious holidays and any kind of celebrations throughout the year are chaotic. They inject this element of uncertainty into your life. So I'd imagine that that also kind of plays into why certain mental health issues are exacerbated during these times. So, I mean, I would say maintaining some kind of normalcy, maintaining some kind of routine. If you don't think you can participate in a fast, then that's maybe something that you should talk about with your spiritual leaders. Yeah, those are just some preliminary thoughts, but we do have more questions. So the next question, can you talk at all about the intersection of spirituality or religion in suicide prevention?
So
also
there
a
is,
broad question.
Go ahead, Tammy, sorry.
No, go ahead. You go right ahead.
There is some research to indicate that religious individuals or individuals who identify as Catholic or Jewish are less likely to die by suicide or try to die by suicide. And one of the theoretical mechanisms around that could be extreme consequences after the death by suicide. But it does play a potential role there. As well, in my own personal clinical work, using spirituality and religion, again, as a source of meaning making or resilience. This life, this thing was given to you for a reason, and what meaning can you derive from it? Or what can you contribute with it? And how might that be a reason to continue living for now as we address this overwhelming feeling of suicidality?
And I think, like you said, Dr. Kaufman, using your religion or spiritual beliefs can actually help in the treatment process. I feel like sometimes when somebody doesn't have a religious or spiritual connection, they're more apt to feel hopeless. Not everybody, I don't have percentages, but I feel like saying, you believe in God, what would God say? Or you believe in your creator, or even like, when people have loss, you talk about like, if people believe in, afterlife, or they believe that their mom is in heaven, you can use some of that in the treatment of people that are suicidal. I mean, you want to make sure that you're careful, but I feel like using spirituality and religion can maybe help hinder that, act of engaging in, suicide itself.
Absolutely, Tammy. I actually did say once to a patient, how angry do you think your mom would be if she saw you show up tomorrow in heaven far earlier than she had anticipated? What would that be like for her?
Yeah, I certainly think it's worth understanding what someone's faith says about suicide and working with that. It can be a real deterrent. At the same time, there are some patients who, even though they say it's against their religion, if they feel really desperate, are going to say, well, God would understand because I'm so, this is so terrible. And so I don't think we can rely on it absolutely when someone tells us that it's against their religion.
Yeah, I mean, I think this also goes back to what we were talking about earlier of how religion can be both helpful or harmful, or sometimes both. I mean, I think that a reason why a lot of people consider suicide or commit suicide is because of isolation. So I think religion can provide connection where there maybe isn't any, whether it's connection to a community or connection to a higher power, kind of like you were talking about, Dr. Kaufman, like making meaning out of things. So thank you all for sharing. Y'all are going to make me start tearing up on this webinar. Okay, next question. When working with clients who are inclined to discuss their spirituality or religion, do therapists disclose their own religious identity? Why or why not would therapists do this?
I would say it depends on the conversation, and it depends on where you're at with your client. Is there a purpose behind it? Sometimes you might say, I've shared, I was raised Catholic. I do not attend church, but I am more spiritual, and that is my belief. So if it's helpful to help that person discuss where they're at or understanding, or maybe they're struggling with, well, my mother wants me to attend church every Sunday, I just don't feel it, then I might share with them. It's completely your choice on which direction you go with your own, religion or spirituality. But like, it just really depends intent and purpose to help the client versus to, I would say, ally with them. I would steer clear of that. I'm Catholic, you're Catholic, we have the same beliefs. That's not always the case.
Yeah, I agree. I try to understand how it's going to serve the patient and what's the reason that they're asking. And focusing on them is usually the best thing, but there are some patients who are just going to have a hard time trusting me unless I say something about where I'm coming from.
Okay, and we can take this as a final question, but how have you handled patients' requests to pray with them, especially if you have a different religion?
Thank you for this question. I actually got this question recently on another panel. I personally, as a clinician, hold fairly firm boundaries. I don't share my religious identity with my patients, even when directly asked. And I do not pray with my patients, even though I believe it can be ethical and appropriate to do so. That's not within my personal boundaries as a clinician. I've sat in the room while a patient prayed. I've helped help a patient make a plan for when they're going to go leave the session and pray or engage in a spiritual activity. And it doesn't sit within my boundaries currently to pray in the room with a client.
I don't know if I would pray with them, but I might be like, I will sit with you. If you would like to pray, you could pray. If you would like to talk to me about your prayer, I'm not sure I would be praying with them per se. I don't know if there's a distinction, but I guess, you know, like Dr. Kaufman says, I would be like, I would sit with them. I would be there with them, but I wouldn't be on my knees holding hands or sitting in the chair holding. I would be like, how about if I sit here while you do pray? I mean, I think that would be more because I'm firm on boundaries too. And I feel like if you start kind of crossing them, then you might end up with, well, you were praying with me yesterday. Why can't you pray with me today? And it becomes like almost like you kind of get in that rabbit hole that you can't get back out of. So we're being just really mindful and careful. I know other clinicians that will do it. So it just depends on the person.
I agree.
Yeah, I would say this also gives me an opportunity to plug some of Tannenbaum's work. But if you are interested in learning a little bit more about how Tannenbaum recommends you respond to situations, we do have a medical school curriculum available on our website for free download. One of our trigger topics is prayer with patients. So we talk about all of the different situations that can be presented. And it's really about doing what you're comfortable with and making sure that the patient feels accommodated and doesn't feel dismissed. I would say that is probably the most important thing is it doesn't matter if you pray with them. It doesn't matter if you are setting a clear boundary and not praying with them. The point is to make sure that they still feel comfortable with you as a provider and that they still feel like they're getting the best care that they can. Also, I just want to shout out to chaplains in general. I feel like they're a very underutilized resource. So if you don't feel comfortable praying with patients, just say, you know what, I'm sorry. I'm not a particularly religious person, but I'm happy to call in a chaplain to be here to support you while you pray. So yeah, definitely use chaplains if you can. That's what they're there for. So I think that is all of our questions for today. And we are almost at 1 o'clock, so we can start wrapping up. But I do just want to say thank you so much for this conversation. Thank you to all of our expert panelists today. I really, really enjoyed this conversation. And I really enjoyed hearing about all of your perspectives and experiences when it comes to mental health and religion. And again, thank you to all the participants for joining us for this conversation today. This is our 4th conversation in our Conscientious Care Conversation series. So we hope that you'll be able to join us for our next one in April. Stay tuned for the date and time associated with that. It will likely be on a Friday at the same time, 12 o'clock. But I think we're having a little bit of difficulty scheduling just because there are a few religious holidays and we want to make sure that we're not double booking ourselves or anyone else. So yeah, I would just say stay tuned to all of Tannenbaum's emails when it comes to getting information about our events. All of our conscientious care conversations are recorded and will be made available on YouTube. So if you did register for this event, you should get an email with that link as soon as it's ready.